Hello, everyone. I am here to join you for the Alamo Breast Cancer Foundation Advocate Chat. And my name is Vernal Branch. I am a 30-year breast cancer survivor. And I am here to do an interview with Afua Richardson-Parry, who is a PhD, has done some research into health equity and screening. So I would like her to introduce herself and tell you so that she can tell you a little bit about herself. Afua.
Thank you, Vernal, and it's a pleasure to join you in the virtual chat. So I'm Afua Richardson-Parry. My background's in pharmacy and pharmaceutical sciences. I currently work as Medical Affairs Partnerships Director at Viatris, and my broad contribution to research is looking at health inequities in cancer screening across three main cancers: cervical, breast, colorectal, or bowel cancer.
Okay. Well, can you please tell me how the question of health equity screening and your perspective for doing this particular type of research?
Sure. So I'm a firm believer in fairness for all, and that includes healthcare. I work in healthcare. And health equity is ensuring that everybody gets access to good care without avoidable barriers. This is a global health priority, and this requires multi-stakeholder approach in tackling that. And I'm fortunate enough to work for Viatris, who believe in healthcare as it is, not as it should be, which means empowering everybody to have access to care in an equitable manner. And so my role, I work with a number of multiple stakeholders, scientific societies, and we also offer, as founding sponsors, we offer an educational program called NCD Academy, which is an online virtual web platform to upskill healthcare professionals in managing non-communicable diseases, of which cancer is one of the top 5. And we've recently launched a course on social determinants of health and health equity. And this supports healthcare professionals with the ability to advocate for equity for all of their patients. And so when it comes to screening and my interest in doing the research in looking at inequities in screening, well, most screening programs are quite broad. These are broad population programs, inviting people at different time points and ages to undergo screening. And so the data is available for most of these national programs. So we wanted to have a look at the existing data, the existing interventions, to see whether it was equitable, whether there were any disparities associated with this. And personally, Vernal, as I shared with you previously, I've benefited from the national cancer screenings here in the UK, both at routine interventions and also when I've had suggestive symptoms, throughout the years. And this is due in part to the long-standing relationship I've had with my GP for many years. And so I feel comfortable to discuss my health and feel that I can have an informed choice and discuss my health. And so he encouraged me at different time points to engage with screening for early diagnosis. And so that's why I'm passionate to ensure that everybody has access to screening in an equitable way.
Okay. Well, I know you worked with quite a few advocates to really start this research. So, what were some of the common things that you, from their perspective, in doing this particular type of project?
Sure. So in our authorship, as you've alluded to, it included cancer survivors, those from patient advocacy groups, researchers, clinicians, and health equity experts. And at the time that we started preparing our systemic review, we met virtually. And so we had a set of semi-structured questions, which allowed us to review the existing data, the existing interventions, looking at cancer screening for breast, colorectal, and cervical cancers. And some of the questions that we asked ourselves whilst we were reviewing the existing interventions were, who were the target groups that were marginalized or that faced inequities? There are a lot of interventions that are happening in the real world setting. Are these interventions evidenced in the literature? And are disparities being addressed adequately? And more importantly, are the views of patients and those that these interventions target, are they taken into consideration? So these are some of the questions that we were sort of, mulling through as we're going through the review. And I would say that we did agree on key themes. Overall, we agreed that these screening interventions are not developed in collaboration with the people that they target, those who are marginalized. Their views certainly have been taken into consideration most of the time. And so we felt the co-development with patients and survivors and patient empowerment groups was key. We also then looked at systems and structural barriers to screening. For example, a lot of the studies that we saw were based in the US, and we sort of saw that, discuss the differences between lack of universal health coverage at point of care versus other parts of the world, such as Europe. And so there was a need to look at having affordable access to healthcare, but then also addressing fragmentation in the system. And looking at how healthcare could be better integrated. Like, for example, having access to cervical screening as well as, breast cancer screening at the same time. That will reduce fragmentation, integrate care, reduce some of the logistical barriers that the people face, and particularly also address the issue with those who are marginalized or unreachable, to improve screening uptakes. We also discussed that screening interventions shouldn't be a one-size-fits-all, and they should be tailored, and they should be based on individual preferences, beliefs, and lived experiences. There wasn't much evidence in literature around digital and culturally tailored interventions, and so we actually sought to perform another systemic review, looking at how digitally and culturally tailored intervention could also be beneficial to screening uptake. The differences we saw was that obviously depending on background. So clinicians were concerned about the healthcare system barriers and lack of reimbursement for services, particularly targeting those who are unreachable. The patients, survivors, and advocates of our authorship were concerned more about involving survivors and laypersons in the community to raise awareness about screening, really working and being active in the community and targeting people where they were. The patient empowerment members of our group were looking at how we can address structural racism and then how this impacts on policy and the system, and therefore might miss the reasons why certain members of the community, particularly those who are impacted from minority groups or marginalized, might not be willing to engage with screening interventions. But then we all did agree that tackling inequity around cancer screening required a multi-stakeholder approach of researchers, academia, industry, but definitely in collaboration with patients. And we felt that that would reduce the inequities that we see with screening uptake.
Since you are in Europe, well, in London, do you see this as a paradigm shift for really changing how we do screening? And will that translate here in the US, do you think? Because you did some digital messaging through social media and other devices. And is this going to be cost effective outside of clinical trials?
Yeah, so I think sort of to take it back a bit, I think historically, and certainly in the literature, you see that many community-based programs have met with some modest impact in terms of, whether it's looking at digital methods or whether it's looking at population promotion as a whole. We find, for example, that HIV prevention and vaccination prevention programs have been successful. But when you look at screening, the results have been somehow mixed. But I do feel that there is more happening in the community. If you look at screening, certainly in the UK, there are many ways of inviting those who are impacted to engage with screening, whether it's being sent a letter directly or being sent text messages or being sent digital educational materials through videos so that they're pre-prepared. And if they have any questions, that they are able to prepare themselves before they engage with the program. And you find that those tend to be more impactful. If somebody is able to either engage digitally through video intervention or through social media, and be aware about what screening is about, why they have to attend screening, the importance of it. It gives them, an opportunity to ask questions of themselves. It gives them an opportunity to prepare for when they come to screen. It gives them that sort of, allays concerns before they come to meet with the program. This is, of course, difficult because if you are not able to be reached or you are not able to have access to digital media, then that's going to be difficult. But we do see that there is an improvement through text messaging, through video interventions and interactive methods and social media. That's happening in the UK quite actively, and we are seeing that these kind of digital interventions are proving beneficial.
So you did this actually out of within a study, if I remember correctly, within was the colon cancer screening. Did you find
Yes.
that it was much improved when people got the right information? And what did the data
Absolutely.
show that people were coming in for their screenings?
Absolutely. So with the colorectal studies, we had quite a few interventions that looked at colorectal studies, and they used the empath, which is a digital technology which is tailored for colorectal cancer. And what that did was that it provided digital information through an app and also through video interventions. So they were able to engage with that program. And what they found is that many were first attended their screening, and then many then went further to undergo undergo colonoscopy as a follow-up because they had had that previous intervention by looking at social media or looking at the app. So we find that is useful. There was also another program where it was tailored to take account of language barriers. So there was a Spanish video that was used for colorectal, those undergoing colorectal screening. They were able to engage with that and ask questions of the healthcare professionals. And having a Spanish speaker, a lay Spanish speaker, as well as a healthcare professional at the point of screening was beneficial for them.
Good. So what do you see for the future? What needs to take place to improve health screenings, and what can providers do to help with compliance to screening? For the future. Maybe I know in the UK you have universal health care there, but how can we use those tools here in the US to make sure that patients are compliant for their screenings?
Sure. I think the first thing that needs to happen is that we need to have a standardized approach in terms of, designing screening, measuring uptake, and also tackling some of those disparities that we've talked about, the structural barriers, the policy barriers, the advocacy barriers. Once we have a standardized approach to methodically analyze every stage of inequity, I think we're in a good place to start to then look at, what compliance looks like and what questions we need to ask ourselves in terms of ensuring that the programs are fit for purpose. I think implementing a comprehensive public health campaign digitally through social media, through apps is important. Increasing access to health insurance, we've talked about making it more universal. developing culturally and tailored interventions through community engagement, really targeting people where they are in the community is important. Reducing systemic and structural barriers, as we've said before, and improving the communication between patients. One of the things that we discussed as authors was empowering patients. A lot of the times, screening interventions are mandated, and so patients feel that they're being forced to engage with a clinical intervention without really knowing much about what the implications are. And so I think it's important to move patients from one empowerment level to another by improving the relationship between patients and their physicians, and thereby helping them to make an informed choice about screening and also about diagnosis and any future diagnosis that might have associated with cancer. So I think all of that needs to happen together, certainly and definitely with the involvement of patients and patient empowerment organizations to ensure that screening uptake improves and some of these inequities are minimized.
Do you think that some of this, there could be biases on both sides, the provider side and the patient side? There may be some biases or not understanding what needs to take place?
Yes, I think so. I think that a lot of the times, the impression from, I guess, maybe clinicians would be, well, they don't want to, attend screening because they're uneducated or because they don't see the importance of it. But I think we also then need to, we talked a lot around the patient voice. We need to understand where people are. We need to understand their socio-demographics. We need to understand why they might not want to engage in a clinical setting. We need to be able to reach them where they are. So I think understanding the patient perspective, their lived experience, and maybe some of the issues that they've had with the healthcare system, with the barriers that are involved, that needs to be taken into consideration. A lot of these are not often answered during these interventions, certainly the interventions that we currently know exist in the literature. And so I think taking a step back to understand the patient perspective, the patient voice, is going to make a difference going forward. So I think I can't stress the importance of the relationship between patients, people, and their healthcare providers. And I think that will go a long way to allay some of the concerns and to improve outcomes overall.
When you've done this work in the community, did you find that some of the patients wanted to be that voice to help improve screening in the community, that they wanted to help and encourage the people in their communities to get screenings?
Absolutely. I mean, I can use my own example where I've had to undergo 3 screening interventions because of suggestive diagnostics. And because of that, I have actually been an advocate to my friends, to my families, and to my peers about the importance of screening, stressing the importance of early diagnosis, differential diagnosis, and treatment. And so I think that's been the same in the studies that we've reviewed, as well as some of the work that we did. We actually realized that a lot of survivors wanted to be the voice to reach out to people. For example, minority women, that there was a suggestion around raising awareness on social media and being able to raise awareness about screening on social media in tandem with, the advertising of healthcare products or beauty, because that's where a lot of minority women may congregate. And so raising awareness about breast cancer screening, cervical cancer screening in those settings would prove beneficial because that's where they congregate. And so there definitely is a need to have survivors in the community raising awareness about their experience. I'm sure, Vernal, you would attest to that. And then also the importance of using social media, culturally tailored interventions, and reaching people where they are. explaining, why there's a need to screen early, and some of the positive outcomes that will ensue once that's undertaken.
Well, I really applaud your efforts because I've done some of that work myself early, uh, almost 30 years ago, starting things in the community to engage with people. So I really applaud everything that you're doing and just thank you for what you're doing in the UK. And hopefully we can apply some of those things that you're doing here in the US. So I want to thank the Alamo Breast Cancer Foundation for this advocate chat opportunity. And thank you, Afua.
Thank you, Vernal, and thank you for having me.
Yes.